The first rib is quite small. Like all the ribs, it's angled downward from back to front. We'll take a special look at the first rib in a little while. From the first rib to the third, the thorax widens in the shape of a dome to about 2/3 of its full width. From the third rib to the seventh, the thorax widens a little further in the shape of a cone. From the seventh rib to the 12th, the thorax narrows slightly, and the ribs become very much shorter. The sternum, commonly known as the breastbone, consists of 3 parts: the manubrium, the body, and the xiphoid process, or xiphisternum. The manubrium is attached to the body of the sternum by a cartilaginous joint, at which a little movement is possible. There's a slight angle between the manubrium and the body, the sternal angle, that's easy to palpate, as is the upper border of the manubrium. The costal cartilages form a series of flexible, springy links between the ribs and the sternum. The first costal cartilage articulates with the manubrium. The second one articulates with the joint between the manubrium and the body, and the third to the 6th or 7th costal cartilages articulate with the body. Here's what the costal cartilages look like in the living body. They're quite flexible. These are the costochondral junctions, where the cartilages join the ribs. The lowest 4 costal cartilages, the 7th, 8th, 9th, and 10th, join onto one another in series, forming the costal arch. The angle between the 2 costal arches is called the infrasternal angle. The xiphoid process projects downwards in the infrasternal angle, where it can easily be palpated. The 11th and 12th ribs aren't attached to the costal arch. Since they're not linked to the sternum, they're called floating ribs. The ribs, sternum, and costal cartilages form an expandable container for the lungs and heart. This large opening, formed on each side by the costal arch and the last 2 ribs, is called the inferior or lower thoracic aperture. It's almost completely filled in by the diaphragm, which separates the thorax from the abdomen. The much smaller opening above, that's formed by the manubrium, the first ribs, and the first thoracic vertebra, is called the superior or upper thoracic aperture. Now that we've looked at the thorax as a whole, let's take a look at a typical rib, the 6th rib. The rib is thin and flat and curved in the form of a spiral. At the back, there are 2 thickenings, the head and the tubercle, which are separated by the neck. The curvature of the rib is interrupted by this angle, which marks the insertion of the iliocostalis, a back muscle that we've seen already. At the front, the end of the rib is hollowed out for the attachment of the costal cartilage. The outer aspect of the rib is smoothly curved. Its inner aspect is marked on the underside by this groove, in which the intercostal vessels and nerve run. As we saw in the section on the spine, the rib articulates with the adjoining vertebrae at 2 points, the head and the tubercle. The head of the rib has 2 articular facets. The 2 facets articulate with the vertebral bodies above and below to form the costovertebral joint. This surface on the tubercle of the rib articulates with the tip of the transverse process to form the costotransverse joint. These 2 joints are synovial joints. They permit the movements of the rib that occur in respiration. The joints between the ribs and the vertebrae are held together by ligaments. The strongest of these are the radiate ligament here and the superior costotransverse ligament here. The movement of the ribs is important in respiration, as we'll see later in this section. Next, we'll take a further look at the first rib, a landmark structure where the thorax becomes continuous with the neck. The first rib is the most tightly curved of all the ribs. It's also the broadest of the ribs. When seen from the side, its upper border lies in a plane that's about 30 degrees from the horizontal. In addition, when seen from in front, its flat upper surface slopes downwards, also at about 30 degrees. The costal cartilage of the first rib articulates with the manubrium of the sternum, not at the top, but lower down, at its broadest part. The first costal cartilage is short and massive. It hardly permits any movement, so the two first ribs, together with the manubrium, move up and down together as one solid arch. Here's a dissection of the manubrium and the two first ribs, with all the other ribs removed. Here's the movement these structures make when we take a deep breath in and out. The upper part of the thorax is almost completely surrounded by the muscles of the shoulder region, which arise from the ribs and also from the vertebrae. These muscles are shown in Volume 1 of this atlas. Just to appreciate how greatly the structures of the shoulder affect the shape of the upper part of the body, we'll add to our picture at this point the bones of the shoulder region, the clavicles and the scapulae. Here's the clavicle, or collarbone. Here's the scapula, or shoulder blade. These two bones articulate with the bones of the thorax at one point only, here. The medial end of the clavicle articulates with the highest point on the manubrium, forming the sternoclavicular joint. It's easy to palpate the clavicle. Here's its medial end. The first rib is difficult to palpate. That's because it lies both below and behind the clavicle, and also because there's a thick layer of muscle in front of it. The lateral end of the clavicle articulates with this projection on the scapula, the acromion, forming the acromioclavicular joint. Apart from this one very movable bony attachment, the scapula is held onto the body entirely by muscles. It's thus capable of a wide range of movement, upward and downward, and also forward and backward around the chest wall. Before we move on, let's briefly review what we've seen of the bones of the thorax. Here are the thoracic vertebrae and the ribs. Here's the head of the rib, the tubercle, the neck, and the angle. Here's the costovertebral joint and the costotransverse joint. Here are the costal cartilages. Here's the costal arch. Here's the sternum, the manubrium, the body, and the xiphoid process. The upper thoracic aperture and the lower thoracic aperture. Here's the clavicle, the scapula, the sternoclavicular joint, and the acromioclavicular joint. Next, we need to look at the important layer of tissue which lines the thoracic wall on the inside, the pleura. To understand the pleura, we need to take a brief look at the way the main structures inside the thorax are arranged. To see what's inside the thorax, we'll look at a dissection in which ribs 2 through 7 have been divided on each side along this line and removed, along with most of the sternum, leaving the costal arches intact. Here are the divided ends of the ribs that were removed. Here's the intact 8th rib. Here's the costal arch. Here's the divided lower end of the sternum, here's the upper part of the manubrium, and here's the intact first rib. Here are the bodies of the thoracic vertebrae. This is our first look at the diaphragm, which forms an almost complete partition between the thorax and the abdomen. We'll take a good look at the diaphragm when we look at the muscles of respiration. With everything removed, the thoracic cavity looks like one continuous space. In reality, it's divided into two separate cavities by a partition, the mediastinum, which extends from the vertebral bodies behind to the sternum in front. The heart, the great blood vessels, the esophagus, and the trachea are contained within the thickness of the mediastinum. To see the mediastinum, we'll put the sternum back in place. Here's the sternum. Here are the divided ends of the costal cartilages. This is the mediastinum. This is the hilum, or root, of the lung. This glistening layer of smooth lining tissue is the pleura, also called the pleural membrane. It forms a complete lining for this cavity, which is called the pleural cavity. Here, the pleura is reflected off the vertebral bodies and onto the mediastinum. Here, behind the sternum, the pleura continues round onto the front of the chest wall. Below, the pleura is reflected off the chest wall and onto the diaphragm, and off the diaphragm onto the mediastinum. Above, the pleura fills in the gap that's created by the curvature of the first rib. Here's the first rib, seen from below. Here's the highest part of the pleura, known as the dome or cupula of the pleura. Here it is, seen from the outside. We'll take a better look at the dome of the pleura from the outside in a more intact dissection. Here's the first rib. Here's the manubrium. Here's the divided end of the trachea, going down into the mediastinum. Here's the dome of the pleura. When seen from the side, the dome of the pleura is level with the proximal end of the first rib. When the pressure inside the chest is raised, the pleura rises well above the first rib. So far, we've been looking at the right side. The left pleural cavity is similar, except that the heart, enclosed here within the pericardium, projects into it. In the living body, the pleural cavity on each side is completely filled by the lung, which will add to the picture. Here are the lungs, discolored by a moderate degree of smoke damage. The layer of smooth tissue which covers the outside of the lung is also pleura. All the way round the pleural cavity, the two layers of pleura touch, with nothing between them except a thin film of fluid. The layer that covers the lung is called the visceral pleura. The layer that lines the cavity is called the parietal pleura. The two layers of pleura, the parietal and the visceral, are continuous with each other here, around the hilum of the lung. Each lung occupies a completely sealed space. Its volume can never be greater or less than the volume of the pleural cavity. When the volume of the cavity is increased, whether by downward movement of the diaphragm or by forward and upward movement of the ribs, the parietal pleura exerts a pull on the visceral pleura. The lung expands, and we breathe in. When the volume of the cavity is decreased, the lung is compressed, and we breathe out. Now we'll move on to look at the muscles that are involved in breathing in and breathing out. The act of breathing in is called inspiration. The act of breathing out is expiration. The whole process of breathing is called respiration. In looking at the muscles of respiration, we'll look first at the diaphragm, then at the muscles that produce movements of the ribs. The best way to understand the diaphragm is to look at it from below. Here are the lower ribs. The muscles between them are the intercostals, which we'll see shortly. Here's the left costal arch. Here's the xiphoid process. The anterior abdominal wall and all the abdominal organs have been removed. Now we'll take a look from below. Here's the diaphragm. It's a thin, continuous sheet of muscle with fibers that converge from all around the circumference to insert on this flat tendon, the central tendon of the diaphragm. The diaphragm arises from a line that goes right around the inside of the lower thoracic aperture, with one interruption, here. To see the line of attachment, we'll remove one half of the thorax and look from inside. The line of attachment of the diaphragm goes from here on the back of the sternum, along the inside of the costal arch, and round to the tip of the 12th rib. Between the 12th rib and the body of the second lumbar vertebra, the diaphragm arises on each side from the fascia which overlies the two big muscles of the posterior abdominal wall. These are the quadratus lumborum and psoas major muscles. Three important structures pass through the diaphragm: the esophagus and the two main blood vessels of the lower half of the body, the inferior vena cava and the descending aorta. This is the opening for the inferior vena cava, the vena caval foramen. This is the opening for the esophagus, the esophageal hiatus. This is the opening for the aorta. On each side of these two openings, there's a thickening of the diaphragm called a crus, the plural of which is crura. The left crus arises all the way down here, on the body of L2. The right crus arises even further down, on L3. The two crura arch over the aortic opening, forming the median arcuate ligament. Fibers of the two crura cross over to surround the esophageal hiatus. When the diaphragm contracts, the whole sheet of muscle, together with the central tendon, moves downward, expanding the lungs and causing us to breathe in. As the diaphragm contracts, the structures below it, the contents of the upper part of the abdominal cavity, are pushed downwards, which leads to this bulging of the abdominal wall when we take a quiet breath in. When we're at rest and breathing quietly, inspiration is produced almost entirely by the downward pull of the diaphragm, with little or no movement of the ribs. In quiet expiration, the upward return movement of the diaphragm is produced passively by elastic forces, notably by elastic contraction of the lungs themselves. When we're breathing vigorously, the diaphragm is pushed upward actively by contraction of the muscles of the abdominal wall. These raise the pressure in the abdomen, forcing the upper abdominal organs and the diaphragm upward. Now that we've looked at the diaphragm, we'll move on to look at the muscles that produce movements of the ribs. First, we'll look at the principal muscles that produce inspiration, the external intercostals and the scalene muscles. Here are the external intercostal muscles. They're thin sheets of muscle that connect each rib to its neighbor. Each external intercostal runs from here on the rib above to here on the rib below. They extend from the tubercles of the ribs behind round to the middle of the costal cartilages in front. The fibers of the external intercostals run forward from above downward. To understand how the external intercostals act, we'll look at a simplified model of two ribs. When we apply a pulling force in the direction of the external intercostal fibers, the ribs move upwards. As the ribs move upwards, their ends, together with the sternum, move forwards. So the action of the external intercostals produces an upward and forward movement of the anterior chest wall. Next we'll look at the scalene muscles, which assist in inspiration by raising the first and second ribs. Here's the manubrium, here's the first rib, here's the second rib. Here are the scalene muscles, anterior, middle, and posterior. The anterior scalene muscle arises from the anterior tubercles of the transverse processes from C3 to C6. It inserts here on the first rib. The middle scalene muscle arises from the posterior tubercles of the transverse processes from C2 to C6 and inserts here on the first rib. The posterior scalene muscle arises from the posterior tubercles from C4 to C6 and inserts down here on the second rib. The action of the scalene muscles raises the first and second ribs and the manubrium in deep inspiration. Now we'll look at the principal muscles that produce expiration, the internal intercostals and the muscles of the abdominal wall. The internal intercostals lie just beneath the external ones, which we'll remove. Here are the internal intercostal muscles. Each internal intercostal runs from here on the rib below to here on the rib above. The internal intercostals extend from the angles of the ribs behind to the end of the intercostal spaces in front. The fibers of the internal intercostals run forward from below upward. To show how they act, we'll look at the model again with the force now applied in the direction of the internal intercostal fibers. As the force is applied, the ribs move downwards. As the ribs move downwards, their ends, together with the sternum, move backwards. The action of the internal intercostals moves the anterior chest wall downwards and backwards. The other important muscles of expiration are the muscles of the abdominal wall. They have two important effects. We've noted already that they raise the intra-abdominal pressure and so push the diaphragm up. In addition to this, abdominal wall muscles pull the lower ribs downward, assisting the action of the internal intercostals. We'll be seeing these muscles in detail in the next section. Here, we'll just take a quick preview of them. On each side of the midline are the rectus abdominis muscles, which go from the 5th, 6th and 7th ribs down to the pubis. Between the rectus muscles in front and the posterior abdominal wall behind, there are 3 sheets of muscle, one inside the other. This one, the innermost, is the transversus abdominis. Its fibers run horizontally. The uppermost ones go from the lowest 4 ribs to insert on this sheet of tendon, which goes to the midline. Outside transversus is the internal oblique. Its fibers arise from the iliac crest and fan out in many directions, the highest ones inserting on the lowest 3 ribs. Outside the internal oblique is the external oblique. It arises from the lower 7 ribs and inserts partly on the iliac crest, partly into this broad tendinous sheet, the external oblique aponeurosis. The most important contribution that the abdominal wall muscles make in the movements of respiration is in the powerful action of forced expiration, as in coughing or sneezing. In addition to the muscles of respiration that we've seen, there are some minor ones that we're going to leave out, since they're unimportant. These are the levatus of the ribs and the serratus posterior muscles on the outside, and the transversus thoracis and innermost intercostal muscles on the inside. In addition to being an expandable container for the heart and lungs, The thorax also forms the foundation from which the upper extremity arises. The muscles of the shoulder region, which cover up most of the ribs in front and all the ribs behind, are shown in Volume 1 of this atlas. Now, we're nearly ready to move on to look at the blood vessels and nerves of the thorax. Before we do that, let's review what we've seen of the muscles of respiration. Here's the parietal pleura and the visceral pleura. Here's the pleural cavity and the mediastinum. Here's the dome of the pleura. Here's the diaphragm, the right and left crus, the vena cava foramen, the esophageal hiatus, the aortic opening. Here are the external intercostal muscles, the scalene muscles, anterior, middle, and posterior, the internal intercostals. Lastly, here are the rectus abdominis, transversus abdominis, internal oblique, and external oblique muscles. Now that we've seen the bones and muscles of the thorax, we'll look at the principal blood vessels and nerves of the thoracic region. Of the blood vessels that we'll look at, there are some that we'll see only in passing, the pulmonary vessels. These are the major vessels which pass between the heart and the lungs. We'll see these more fully in Volume 5. We'll start with the arteries, and we'll begin by looking at the largest artery in the body, the aorta. Here's the left pleural cavity, with the lung removed and the heart and mediastinum undisturbed. Here's the aorta, partly hidden beneath the pleura. It emerges from the left ventricle of the heart, arches over, and runs down alongside the vertebral bodies. It leaves the thorax by passing through the diaphragm and into the abdomen. To get a better look at the aorta, we'll remove the overlying pleura and part of the pericardium that surrounds the heart. We'll also remove the body of the sternum and the lower half of the manubrium. The part of the aorta that lies within the thorax is called the thoracic aorta. It's spoken of as having three parts: the ascending aorta, the arch, and the descending aorta. The aorta arises here from the left ventricle. To its left is the pulmonary trunk. To its right is the superior vena cava. The ascending aorta runs upwards with a slight curve to the left. It has no branches. The arch of the aorta makes a complete 180-degree turn. Beneath the arch of the aorta is the pulmonary trunk, dividing into the two pulmonary arteries. Here's the left one. This is the ligamentum arteriosum. Also beneath the arch are the left main bronchus and the left pulmonary veins. To the right of the arch is the lower end of the trachea. Before we move on to the descending aorta, we'll take a look at the three major arteries which arise from the arch. These are the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. The brachiocephalic trunk, also known as the innominate artery, divides to form the right subclavian and the right common carotid arteries. Here are the origins of these three arteries: brachiocephalic, left common carotid, left subclavian. Here they are, emerging through the upper thoracic aperture. To see them clearly, we'll remove these veins, the right and left brachiocephalic veins, which unite to form the superior vena cava. We'll also remove the rest of the manubrium and the two first ribs from here to here. The brachiocephalic artery divides here into the right subclavian and the right common carotid arteries. Here's the left common carotid. Here's the left subclavian. The subclavian and common carotid arteries are shown in volumes 1 and 4 respectively. In this section, we'll look at one branch of the subclavian that's important in the thorax, the internal thoracic artery. To look at it, we'll put the first rib and the manubrium back in place. The subclavian artery arches over the upper surface of the first rib, passing behind the anterior scalene muscle. Before passing behind the anterior scalene, it gives off these branches: the thyrocervical, the vertebral, and this one, the internal thoracic. The internal thoracic artery runs downward and forward over the dome of the pleura and passes behind the first costal cartilage. To see where it goes, we'll look at a dissection of the anterior chest wall by itself, seen from behind. Here are the two internal thoracic arteries. After passing behind the first rib, which is here, each one runs down the inside of the chest wall, just lateral to the sternum, in front of the transversus thoracis muscle. Its branches supply the anterior chest wall. Its distal continuation, known as the superior epigastric artery, supplies the upper part of the anterior abdominal wall, as we'll see in the next section. Now we'll return to the aorta. We've seen the arch. Now we'll look at the descending aorta. To get a clear look at it, we'll take the heart and the arch of the aorta out of the picture. The descending aorta runs downwards in close company with the esophagus. The esophagus lies medial to it up here, in front of it down here. We'll remove the esophagus. On each side, the descending aorta gives off this series of posterior intercostal arteries, one for each of the intercostal spaces except the first two. Each posterior intercostal artery passes along the deep aspect of an internal intercostal muscle, in company with an intercostal vein and nerve. It stays close to the lower border of the rib, in this groove that we saw earlier. Now we'll move on to look at the principal veins of the thorax. We'll look at the two largest veins in the body, the superior and inferior vena cava, which enter the thorax from above and below and empty into the right atrium of the heart through two separate openings. We'll also see the veins of the wall of the thorax, the azygos veins. We'll start by looking at the major veins which contribute to the superior vena cava, the subclavian and internal jugular veins. On each side, the subclavian vein, the principal vein of the upper extremity, joins with the internal jugular, the principal vein of the head and neck, here, behind the medial end of the clavicle, forming the brachiocephalic vein. The two brachiocephalic veins enter the thorax and unite, forming the superior vena cava. To see the subclavian and internal jugular veins, we'll remove the major muscles which lie in front of them, the pectoralis major and sternocleidomastoid muscles. Here's the subclavian vein, coming up from beneath pectoralis minor and passing beneath the clavicle. Here's the internal jugular vein, with the omohyoid muscle in front of it. To see where these two veins join, we'll remove the clavicles. The subclavian vein passes over the flat anterior part of the first rib. The anterior scalene muscle separates the subclavian vein from the subclavian artery. The dome of the pleura is just behind and beneath the subclavian vein. The internal jugular vein lies in front of the common carotid artery and lateral to it. On each side, the subclavian and internal jugular veins unite to form the right and left brachiocephalic veins.